My name is Rebekah Angove. I am with the Patient Advocate Foundation. We are a nonprofit. We serve patients across the United States, and we do so telephonically. So we are headquartered in the Hampton Roads area. My personal role there is the VP of Patient Experience and Program Evaluation, where I do a number of different initiatives and projects focused on engaging patients, caregivers, and other stakeholders in care policy and research, while also ensuring that our internal programs are meeting the needs of patients and caregivers and are being impactful to the wider community. And I'll turn it over to Rebekah to briefly introduce herself.
Hi, everyone. I'm the other Rebekah Kirch, and I sit in Washington, D.C. at the Patient Advocate Foundation's advocacy affiliate. And what that means is we translate all the findings that Rebekah A. sends our way into public policy and advocacy initiatives to help raise the different issues that are percolating across the country. Those that rise to the top are areas that we want to make sure that we help fix the system in bridging gaps. And we do that through public policy, through advocacy with our volunteer network, and help give people more confidence to know how to advocate on behalf of themselves, their loved ones, and their communities. And so that's how our two organizations work together. And Rebekah and I sort of work hand in glove with research and policy advocacy joined at the hip.
So today we're going to take you through just a few slides. You know, I'm always I always forget to put objectives. We have them here, but really we just want to talk to you a little bit about the patients that we serve, their experiences, both with care as well as their cost experience, their care goals, and how financial distress and the challenges and barriers that they have really lead to influencing their decision making. And then just a little bit of things that we've learned around patient preferences and experiences related to communication, specifically about how they talk about cost of care and their care goals. So as I mentioned before, we are a nonprofit. We look at NPAF and PAF as sister organizations. Really, PAF is positioned to do the direct services. So we work with patients one-on-one in a number of different ways. And then we take what we learn from helping patients one at a time. We collect their experiences. We have a number of survey and other outreach initiatives to even deeper understand patient experiences specifically related to underserved patients. And then, as Rebekah said, we take all that data and we share it with our sister organization to help them advance their policy work. Rebekah, is there anything you wanted to add to your mission?
No, not here.
Okay. So a little bit about us. When I say direct patient services, we have a constellation of services that work together to really help patients with chronic or complex illnesses that are facing financial distress and or have social needs. And so you'll see a number of these services are directly related to financial distress, namely the financial support programs and the copay relief program that we have. But we also do case management, which at its core is really financial and social need navigation. And oh, my slides are moving on me. So this case management, the financial and social need navigation, is really at the heart of our mission, is where we started. Patients can call us and they do not have to fulfill a special income threshold. As long as they have a complex and or chronic illness, we will help them with any, try to help them with any need that they have. A number of our patients call us because they're having challenges with transportation, they're having challenges paying their rent, mortgage, their daily cost of living, or we also do a lot of navigation around insurance as well as education. So what insurance products do I need to be in? How can I enroll in insurance? How do I handle when I have a denial? Can you help me with an appeal? So we really do, you know, the entire spectrum of support from, you know, a kind of one-off, you know, I can't pay my rent this month, or I can't get to my appointment, to I have this overwhelming bill and it's wrong, or we help patients negotiate with their care provider around, you know, lower cost, or if there's charity care. And we also, you know, work with them to understand their insurance and their bills, and help them navigate the insurance side of it. So we do that telephonically, one-on-one with patients. And then we also have a number of what we call education and empowerment resources and tools. And those are PDFs. You know, they range from everything from like a PDF flyer that we actually will print out and send to patients who need the paper copies, all the way to multi-module online curriculums to help train patients around certain topics, patients and caregivers. On top of this, you know, we really have at our core, we're helping the most vulnerable and the most underserved citizens. And so we have a strong commitment to both community engagement and health equity, and have a number of initiatives around that. And then we also are doing some health research initiatives to really understand how the work we do impacts the broader community, but also to inform some of our healthcare transformation projects, as well as the policy work that Rebekah does. So that's a very brief snapshot of what we do, and I'm happy to field questions and go into depth in any area that the group wants. A little bit more about who we serve. So, you know, we call it complex and chronic health conditions. Right now, we have about 600 diagnoses represented. What's really interesting is that we started really focusing in on cancer, and that was 25 years ago. We've since expanded, and we do everything from blood disorders to, you know, we have a strong group of HIV and AIDS patients that utilize our help. So, you know, we have a group of rare conditions that we help. So we really are diverse in the type of conditions that we serve. As you can imagine, just the nature of our work is around access and affordability. So we do have, my slides are trying to rush me. We do have primarily low-income individuals and families. You know, we have described them as the working poor. And so the majority of our patients, they are working, they are insured. They're just struggling to make ends meet. And it's usually due to the financial implications of a diagnosis, a major diagnosis. We have a very diverse racial and ethnic diversity within our patients, as well as diversity around, you know, urban, rural. And then also, you know, we think about rural as being those that are underserved, but we also serve a lot of patients in, you know, medical deserts, or those that have medical shortages. And, you know, the typical patient that comes to us, I mean, we have such diversity in who comes to us and why, but there seems to be this perfect storm and constellation of challenges that happen when you have a complex or catastrophic diagnosis. There are employment impacts that patients come to us with. And so when there's employment challenges or income disruption, that impacts the cost of care. The medical debt piles up and they have an inability to pay, leading to emotional distress. And then, you know, that distress also kind of creates just a vicious cycle, right? And if the diagnosis comes with any sort of functional impairment, that will in turn affect their employment. And this is just a vicious cycle that a lot of our patients and caregivers come to us, they can't get out of. And so what we try to do is find them solutions that are going to be long-term solutions, whether that is trying to find a better insurance, product for them or enrolling them in insurance. We've helped patients with, their disability. There's a lot of things that our case managers do, and they're always looking for that long-term solution as opposed to, a single $300 transportation grant. Those are great, but next month the challenges are gonna be there. Some of the things that we've learned from our patients, and my colleague Rebekah loves this slide because it really hits home to what our patients and the people that we serve are going through. The top treatment concerns. So these are the things that are of utmost concern. We asked patients, we gave them a list. We said, what are the things that you're most concerned about when it comes to your diagnosis? And the financial cost of treatment was number one across the board. That's more concerning to patients than dying or the long or short-term side effects. So this is not something that patients go through their treatments and once they're done, then they kind of worry about that later, right? Like, oh, we'll figure out that later. Patients are coming to us and telling us that the financial cost of treatment is a driving concern around how I make care decisions. And it's also a barrier to getting the care that I need. We have patients that have told us without your support, I would have died because I couldn't get my medication, right? These are decisions patients are making. I don't want to leave, we've heard patients say, I don't want to leave my family in bankruptcy or liquidate, the small nest egg we have. And so I'm just going to die. I'm not going to get treatment. And these are things we hear over and over from our patients. So this financial distress is really a very real thing that's top of mind for patients as they're being diagnosed and through their care experience. So, I touched on this a little bit, but this is what we do. We try to listen to patients that call us, really kind of filter through what they're telling us and figure out what the immediate problem is, and then identify ways that we can help them short-term and long-term, what those resources may be that are out there. And we do that, we're fairly high touch. So on average, it takes about 10 days to close a case. And we have about 20 contacts per case. 15 to 20 is our kind of average. And what does that mean? So we're helping patients talk to the financial office, their provider, and we do a lot of conference calling. We talk, we help patients fill out forms. We have patients that have even sent us things. We'll fill it out for them. We'll send it back. They'll sign it. So it's not just a service where we say, okay, here's a list of resources. Good luck, right? This is really a high touch, hands-on service. And I think something that we don't talk about enough that we really do is a lot of our patients report that it's just really nice to talk to somebody about what they're going through. Not that we, handle emotional or mental, we don't have any counselors or we don't do any mental health services, but to just, we get feedback all the time, knowing somebody is on my side, somebody reassuring me that I'm on the right track. Somebody really helping me, like having that support is something that is very valued by the patients and caregivers that we serve, and something that other, caseworkers, social workers don't always have the time, the bandwidth, or the understanding of some of these complex, especially on the insurance side, some of these challenges. And we can just be a supplement or a support for that. We actually get a handful of caseworkers and other supportive, community health workers calling us, and sometimes we actually help them out with some of the more complex cases. So we're happy to be a support in those areas. And I'm gonna just pause here and let Rebekah jump in. She's my wingman today, but we did want to send her really on the direct patient service work. But I want to let Rebekah talk a little bit about how this direct patient service work that we do actually influences and kind of the vision for the bigger landscape and how we're trying to improve health and healthcare at a more macro level.
Thank you. The bedrock of our organization are these services that we call internally case management services. That's just our internal verbiage for this navigation that we're providing. But you have to be a little bit lucky and get referred to us through the relationships that we have with different disease organizations, whether it's the American Cancer Society or one of the AIDS organizations or otherwise, to find your way to us. And usually patients and their families are in a pretty dire circumstance by the time they find their way. But with 25 years of amassed expertise in how to help people feel heard and understood around the concerns that they have outside the context of their medical condition, but directly the result of it, I think that we're uniquely positioned as an organization to help bring to scale what we've done as a pilot project, if you will, philanthropically funded. So make it a standard of practice is our ultimate objective through public policy initiatives that we're starting to really focus on now. So taking the by the ones work that Rebekah's described, that's very valuable across the country, and bringing it to the masses by educating policymakers and other influential stakeholders about the value of these services in helping patients and families identify their priorities, adhere to recommended treatment, and see themselves through. So what we did to start, I apologize for the phone in the background. The financial and social needs navigation services that we have built are a critical part of sort of educating different audiences that this is a key need that needs to be a standard of practice. That means equitable access to these services, reliable assessment. Rebekah talked about this. There's an art and a learned skill to the kind of communication that's required to tease out from people what matters to them most, because the health system conditions everyone to talk only about their medical condition, not about the swirl of concerns that they have, the total cost of care, things like food, energy, housing insecurity, childcare, transportation, all of those elements. It takes skilled communication to tease out these different aspects and sort of tell the broader story of treating the person beyond the disease. So we want to make sure that there is an equipped workforce that's able to reliably assess for these needs through skilled empathic communication, and then emphasize the research that we know is required through health services research and otherwise to evaluate the impact of these services, both in terms of how they help improve quality and quality of life and lived experience for patients and families, how they improve efficiency actually of the health system and how care gets delivered, and how they might improve the cost picture for government programs. Getting the right people enrolled in Medicaid early enough, getting the right people to disability benefits early enough that these sort of benefits as they were intended are made part of the plan instead of something when the circumstances have become dire. So we have a policy agenda that fits with what we know are the priority needs of patients and families. And our intention is to translate these policy principles into specific action steps, looking through that health equity lens and selling this, if you will, in the context of advocacy as a key way to address some of these social determinants of health that can make a difference in people's lives and the disparities that result in health outcomes. So that's the focus and the hook of the advocacy agenda that we have to sort of make financial and social needs navigation and a well understood, if not household name, that people will demand, that health systems will be equipped to help supply, and the government will invest in, so that everyone who needs these services, not just the lucky few who get funneled to Patient Advocate Foundation or some other partner organizations who do similar work, though we're one of the best in class, we need this to be available for everyone reliably everywhere, especially those populations who are underserved. They need to be moved to the front of the line. Back to you, Rebekah A.
Such a hard act to follow. And I just want to highlight, I'm sure after listening to Rebekah, you can really kind of see the kind of that data and evidence as being the connector, right? And so when you think about the research initiatives and some of the evaluation that we're doing, it really is to get a kind of the evidence required to push the policy. So I'm gonna just go to the last slide for a moment. This is us. So screenshot, copy, paste, if you wanna get a hold of us after this presentation, but I'll stop screen sharing in a moment, and we'd like to use the rest of the time for questions, discussions. We're happy to sit back and just enjoy the discussion of the group. Because we want to hear from you.
Thank you very much, Rebekah A and Rebekah K. Those were wonderful overviews of what you provide. And again, what I really love about what you've shared is the specifics of the Patient Advocacy Foundation, but then the need to do more than just help people on a one-on-one basis, that to raise to that higher policy level is so critical. So as you can see, we have some questions in the chat. And in our audience today, we also have some really key providers. And so I'm wondering if you, how do you partner with organizations? How can they maybe work with you for referrals? You've talked about working with the American Cancer Society and the Alaska AIDS, or the American AIDS Society. Can you maybe talk about that for a minute? And then Kai Holland has a very deep question, but I'm going to ask him to unmute and maybe shorten that question and ask it after that.
So absolutely, there are opportunities to partner with us and for us to be kind of a supportive arm to what you're doing. That is something, we have our community outreach specialist, and he is not on this call, but that's something that we've done both formally and informally with partners in the past. So if anybody is interested in that, I would recommend to reach out to me, and I can connect you and get you more detail.
Great. Thank you. Kai, go ahead.
Thanks, Jacqueline. I threw a typical Kai question a little too much. I'm fascinated with your ability to connect with people, to help them navigate the challenges of our healthcare system, including the insurance system. I'm wondering what your thoughts are, though, about the specific navigation assistance that I see patients needing as they directly interact with a care provider on their care situation, their treatment options, simply understanding what the options and decisions are, maybe even being able to ask the care provider a really hard, challenging question about that doesn't make sense. And I see you providing a lot of really important administrative and program level support. I'm wondering what your thought process is, or if you see, or maybe you actually have a way to help the patients with their actual direct plan of care and navigating those issues, particularly for those patients that don't have a partner or a friend that takes an interest in realizing that that cancer patient isn't going to be able to keep track of this stuff. Somebody has to go along to help them navigate this. Complicated question. I'm curious kind of what your thoughts are.
It's a great question.
Yeah. And let me give the can disclaimer, and I'm going to then let Rebekah give the deeper answer. So PAF and our navigators, they do not do any sort of care coordination or decision support when it comes to talking about which care options. And so that's something that we have to be very careful of. We don't give medical advice, and I think at the very most, we help patients advocate for their rights for a second opinion and other options. But we don't do care coordination or that kind of level of care navigation. the topic that you touched on around communication is near and dear to our hearts, because we do know how important it is. And I'm just going to hand it over to Rebekah, who's to my left. So now I'm going to do a Brady Bunch. But she can answer this from the PA or the NPAF perspective.
Sure. And what you're talking about is so critical, that someone has an advocate in the room with them in a clinical setting, for example, because we already have this hierarchical challenge. And if you're from an underserved population, you may feel even more marginalized by the experience, depending on the competence of the practitioner you're seeing. What we can do, we can't go in every room with people when they're having their clinical encounter, but what we can do is help equip them with the skills and confidence to be able to be prepared to talk about the things that matter to them beyond just what's the matter with them. So what we do is, through our advocacy program and our volunteer network, which is peer-to-peer, we help equip patients and caregivers with the skills they need to feel more confident, possibly even more assertive. And we give them talking maps and scaffolding for having the kind of conversations to support shared decisions, to support care planning. And I'm glad you used those words in particular, because we have an arc of 4 different community outreach campaigns across the year that follow the trajectory of patients and families. The first is Be a Hero, Make a Plan, which is specifically around providing talking maps and help for people to plan for their clinical encounter before they get there. A little bit of a if this, then that. Think about these things before you go in the room. Make sure that, and give them prompts to think about what matters to them, so that when the doctor has their hand on the doorknob, they did get to the stuff that they needed to talk about in that conversation first. It doesn't happen as the hand goes to the doorknob. And that they have pre-thought through some of the things that are most pressing on their mind, because the data, and the reason that slide that Rebekah shows about financial distress being a fate worse than death is such a key aha moment for clinicians, never gets asked. You know, what's bothering you most? Palliative care principles are sort of the backdrop for the case management that we're talking about. And there are very few practitioners outside of palliative care who have those communication skills. So we're working through our advocacy program, peer-to-peer, to raise public demand for the type of advocacy that patients are demanding it, that their conversations be with clinicians who are responsive to their needs, their concerns, rather than the other way around. And so there's a whole deliberate advocacy structure and training curricula that we help support our volunteers to do, and they go out into their communities and build that wherewithal, among others, and so on and so on. So that's the nature of how we try to scale those sorts of skills.
And we do have some evidence that our navigation services and patients that have gone through our navigation services have an increased confidence in talking to their care provider. They have an increased understanding of, increased health literacy, increased engagement. And so we are trying to track some of those things, but it's a needle that doesn't move very quickly. And also, we try to be supportive however we can when patients do have to be in, it's not in real time during care, but if they are having to have calls with their insurance or with the financial office of their provider, we do 3-way calls. And so not only we try not to do 4, we try to do some modeling, which helps a little bit.
I want to say thank you both. I'm mindful that we typically end at 1:30. Kay has asked a question about whether this is available in Alaska right now. I will stay on and we can answer some additional questions. So Kay would like to know if this is available for Alaskans.
Yes, so we do serve patients in every state, and we have had patients, caregivers call us from Alaska. So yes. I put our website in the chat as well.
Yes, Dr. Brown.
we sort of have an elephant in the front room in Alaska with a situation called Alzheimer's disease and related disorders. Some of these people can't get the care because they don't fall into the gap. It's kind of like the canyon, the Grand Canyon, the space in the Grand Canyon. Some Alzheimer's can get that care under Medicaid, Medicare, Medicaid, but people who have other related disorders cannot. And we have to go get waivers to help people get some kind of care. I'm interested in your experience with this whole system of Alzheimer's disease and related disorders, and have you had experience, and is there light at the end of the tunnel for this bunch of people?
So I am knowledgeable of this problem. I wish I had my team of case managers on to speak to it. So I don't want to speak out of turn because I'm not the one on the front lines doing the work. I'm on the back end data and evaluation side of it. But I do know that our case managers have encountered this challenge, and I know that when they have to work through getting people approved for things, you know, they have done this in the past. I don't know how successful they are, and I can't speak to that, but I would, Dr. Brown, I'd be happy to put you in touch with the head of our case management department. And, you know, I'm sure she'd be happy to discuss it more. I'm sure she has a lot to say about it.
Thank you.
There are so many challenges with dementia care nationally, and I don't know if there are extra burdens in Alaska that you're describing, maybe because of the vast country side and lack of availability of care, but dementia care has its own special challenges just as a general rule. So your point's very well understood here. And one of the things that we try to do is identify through case management, where are the problems that are intractable that we can then bring to policymakers to try to identify changes. Most recently, an example of that is ALS patients were having to wait too long to be eligible for disability benefits. You know, the trajectory of life with ALS is too short to benefit from Social Security disability that these families need desperately. And so policymakers changed that, just as end-stage renal disease makes you eligible for Medicare. So there are ways that we can take the information and translate it into potential policy changes. And I would say that the Alzheimer's lobby of organizations is very effective in what they do to try to address these gaps. And beyond that, we'll be very interested to hear more specifics about what are the types of gaps that I think the details are very helpful, and connecting that with what our case managers do or can't do is a way that we can then identify policy solutions that we might try to advance to tackle that elephant in the room.
Thank you.
Thank you very much. And we have Kay Papacristo with the Alzheimer's Resource of Alaska also wanting to connect. So I'll make sure that that connection is done. I want to follow up. Kai has very generously provided us with an easier question this time. And
I read that. Do you want me to start?
Yeah, go ahead.
So Kai, I love this question. So basically it's about, you know, innovation and entrepreneurship. I think there's a lot of opportunities. I think there's also a lot of untapped opportunities. One space that I personally have been working in is thinking about using technology for patient engagement, and specifically how can technology be designed not only to facilitate what's happening in the provider side and for workflow and patient satisfaction and experience, but also thinking about how it can actually serve to add value to patients. I specifically think an area of opportunity there is to think about how technology can be leveraged not only for satisfaction surveys and you know, coordinating appointments, but facilitating conversations around cost of care, because that's something we really advocate for. Patients have a really hard time getting good information on what the cost of their care is going to be, and therefore they can't incorporate into decision making even though they want to. which means decisions are made that they can't afford. And they just don't pick up a prescription, right? They don't come to a follow-up appointment. There's been a lot of policy put forth around price transparency, but to be quite frank, it's abysmal when it comes to the patient side. It's not useful for the actual, consumer, if you will. And so, I've worked with a couple tech companies that want an advisor, but I think this is a big area that really private industry can be developing very lucrative, very valuable tools that can support patients in this way. So I think that's just one of many opportunities where I think the private sector and entrepreneurs can help this cause.
I really love that, Rebekah. We actually have a group called Caregiven that will be presenting, I believe, in May or June with this idea specifically of trying to help people. And it's a kind of a virtual chat box that allows parents and children and everybody to kind of communicate. So that's really, I'll make sure that you know about that and make sure that this community does. Again, happy to stay on. Does anybody have any more questions that they'd like to ask? And I don't hear any. I do want to say that the statistic that you shared about people being more afraid of the financial ramifications rather than dying really stays with me. I mean, it's one of those just moments that makes you realize how terribly alarming this is, not only for individuals and their families, but for our society. So anything that we can do to increase these conversations. The other thing, having looked at your websites in order to get ready for this meeting, you all have so much valuable information on your website. I encourage everybody to go to those websites. For example, everyone probably knows that the affordable care plans are now opened up again, and you can access those if you need to. And these websites have all kinds of resources for trying to compare the sites and things like that. So anyone who works with people who need this assistance should definitely be directing people that way. So so with that, unless there's any more questions, I am going to say a huge thing. Oh, Eric, do you have a question? Oh, you're saying goodbye.
You're saying goodbye. Goodbye, Eric.
Say goodbye. All right, awesome. Thank you very much, Eric, for coming. And thank you everyone for coming. This was a really important presentation to come to. Thank you so much, Rebekah Angove. And thank you, Rebekah Kirch. Really valuable work you're doing. And thank you so much for doing it. And thank you for coming today and presenting.
Thanks for welcoming us.
Thanks for having us. And I'm sure you'll send a follow-up, but anybody that wants to connect, please feel free to reach out. We're both very, very open to new collaborators and sharing anything that we can to help you out.
Awesome. Thank you so much. Absolutely, I will. All right.
Take care, all.
Good afternoon.
Bye, everybody.
Bye-bye.
Good afternoon.
Okay, goodbye now. Thank you. You guys you're rock stars. You're awesome. That was
Did that serve, since I still have you on, did that fit what you hoped it would be?
totally fit. I have to say, the fact that everybody wouldn't leave is a huge indicator.
Well, and I'm so sorry. I thought we were slated for hours. So in my head, I thought we had till 5:50 for some reason. And so I would have even cut our presentation even shorter, but
No problem. I thought that was probably, again, communication. I probably didn't.
No, I'm just so used to hour meetings. I think that was just my brain.
I kept it pretty short just because I don't know. I was attending too many hour-long meetings, I think. So I'm like, we're doing this one in 30.
People are busy. No, I appreciate it. Well, thanks for having us. If you could just circle back in an email with me and maybe let me know who wanted that ADRD information, because I'm actually going to pick the brain of the director of our case management and try to get some information from her and see if it would be appropriate to just share the information or just connect them. So,
Okay.
So we'll figure out how to do that.
So you have two people there, and so it'd be two slightly different conversations. Dr. Brown, she's amazing. I think she's like 85 and she's still active in her community. I mean, she's just amazing.
It's who I want to be when I grow up.
I know. But the other person, Kay Papacristo, who was having trouble, they are the lead Alzheimer's organization in Alaska. So there's going to be slightly different conversations. And I'm wondering if, we could maybe introduce them separately. So you're welcome to maybe share an email with me, and then I can make an email introduction to them both. Dr. Brown loves to be informed, but she's mostly kind of, just participating at a community level, and Kay Papacristo is doing more on the organizational level right now.
Okay. Yeah, just make those introductions. And I need to check too. I didn't know off the top of my head. I don't know if Alzheimer's and dementia is an included or an excluded disorder. And so we may be perpetuating this challenge because we don't do a lot of mental health services. And I think that might fall under that umbrella. But what we do, most individuals have another chronic disorder, and it could be something as simple as diabetes, right? So then we can help those individuals. So, we may be perpetuating the challenge that they're facing, but I would still love to just talk to them more. So if you can make that introduction, I'll do some digging on my side, and I'll see what we can't do.
Sounds good. Well,
okay.
super grateful. So thank you very much.
Yeah, thanks for everything, Jacqueline. Enjoy the rest of your afternoon.
You too. Thank you. Goodbye now.